SRL Diagnostics.
Hi, my name is Dr. Aparna Dhar and I'm the Head of Department Medical Genomics and Genetic Counseling here at SRL Diagnostics. Today we're very briefly going to talk about precision oncology. We know that one-size-fits-all therapies are being replaced by individualized treatments and disease intervention. Precision oncology essentially describes the disease is being treated or strategized in cancer medicine, and it's being done based on understanding the tumor biology of the cancer. So essentially, the strategies range from anywhere from using targeted therapies to the use of the data that we get from the next generation sequencing. Now, if I look at the molecular landscape in general, we'll start with a poster child, let's say lung cancer. And if we just look at lung cancer, especially the NSCLC subtype, there are around how many mutations? We look at what are our biomarkers. We look at EGFR, we look at ALK, we look at ROS1, BRAF V600E. This is what it used to be. But now, in addition to this, we look at NTRK, we look at RET, we look at MET exon 14 skipping. We're looking at KRAS 12C. We've evolved, and all of these are actionable. In addition to that, another very promising area is ovarian cancer. So while yes, we've got bevacizumab, we've got our platinum chemotherapies, we've also got our HRD, which is homologous recombination deficient cohort. Interestingly enough, in the uniqueness of ovarian cancer, and especially a high-grade serous, is that 50% of these patients are eligible for a PARP inhibitor because they are homologous recombination deficient. So what that essentially means is that they have a mutation so there are two ways of doing it. One is the mutational landscape, which means we've identified a mutation in our, a germline or a somatic mutation in our genes that are involved in homologous recombination repair. Or we look at the genomic landscape, which means we calculate the genomic scarring. And a combination of this helps us understand if a patient is a candidate for a PARP inhibitor. And with ovarian cancer, it's around 50%. If I look at my breast cancer patients, and again, we know they are classified based on their subtypes, be it TNBC, be it H hormone receptor positive and HER2 negative patients, they are very molecularly diverse. Again, you've got anywhere ranging from PIK3CA, where we know in triple negative we use AKT inhibitors, whereas in our HR positive we have a target for a PIK3CA inhibitor. So again, it's diverse. You've got NTRK, you've got your germline BRCA mutations, you've got your immunotherapy as an option, you've got your agnostic markers. CRC, colorectal cancer, you've got your RAS mutations, BRAF, HER2, immunotherapy, especially MMR or MSI up front. And if we look at our biliary tract cancers, they are actually very, very heterogeneous and based on their anatomy, which means intra, or gallbladder, they're molecularly very diverse. So FGFR2 fusions and IDH1 is synonymous with interhepatic, whereas HER2 is synonymous with intrahepatic and your gallbladder cancers. And then we've got our BRAF and our MSI and our NTRK, which is right across the board. So in today's day and age, when we are treating our patients, understanding the whole story becomes extremely important. Whether we're doing next generation sequencing, which is DNA and RNA sequencing, or we're doing precision protein IHC, which is essentially looking at something like an androgen receptor. If that's positive in a triple negative breast cancer patient, we know this targeted therapy, PD-L1. And then we do germline testing. A combination of all of this actually helps us decide as to what could be the best treatment plan for our patients. Precision oncology holds the promise of an improved efficiency, better care, and most importantly of all, effective treatment and cost reduction for our patients. Thank you.
SRL Diagnostics.